So the final session today is looking at Chris Whitty's report from last year on coastal health and having a think about how we build on it. I'll introduce you to Professor Chiara De Cesare, who's the Director of the Institute for Public Health and Wellbeing here at the University of Essex. And she is going to chair the panel after we've heard Chris Whitty.
Thank you very much, Phil. And I don't need to say anything. I don't need to introduce you to Chris Whitty. What we do now is that we watch the video, and then I will invite the panelists to join us and for a conversation as dynamic as possible.
Thanks very much for inviting me to this Eastern Arc collaborative meeting. I was asked to talk about some of the potential research interests coming out of my annual report for last year, which is on coastal towns, which obviously includes many of the towns in your area, east and some parts of the southeast. So I'm going to just share my screen. So this is a report I and colleagues did last year, and just starting off as an illustration, this is coronary heart disease prevalence in around England, and as you can see, the coastal strip as a whole, including importantly East Anglia, Essex, and the coastal parts of Kent, have very high incidence and prevalence of coronary heart disease, as with several other diseases. And this coastal effect, for complex reasons, and I'll come through some of them, but it's not really fully understood. There is an increased prevalence and incidence of multiple diseases, including cardiovascular diseases, hypertension, diabetes, so risk factors, as well as conditions, cancers, but also some mental health conditions and several other major risk factors, including smoking, all concentrated along the coastal strip. Now, the reasons for this interact, and no two towns are the same, but one of the general principles actually we came across as we were looking at this question in England, and it's true elsewhere in the UK actually, is that there's a lot more in common between most of the coastal towns and than there is between them and their nearest inland neighbours. So the coastal towns have a specific set of particular risk factors that lead to this increase in ill health. The first is demographic. Populations tend to be older, and here are the census data. You can see the east here and the southern coast. People over 65 are significantly higher proportions of the population than they are in the central belt. Partly explaining this, but also contributing to other aspects of relatively ill health, is migration. Younger people tend to out-migrate in their late teens and early 20s for study and then subsequently for work. And then there'll be some degree of in-migration in later years. But this out-migration means that there's a group of people who would otherwise be driving the economy and indeed contributing to the proportion of people in good health is lower. There is relatively high deprivation in multiple parts of the coastal strip, and this depends on a number of factors, but it's very often because towns were essentially built around a single industry, classically ports, fishing, and more recently a particular version of coastal tourism, which then moved on, leaving the town behind, but with the major industry on which they depended no longer present, or in a much smaller form than it was in the heyday of the town. Unemployment rates are relatively high in many coastal towns, and particularly for those which are dependent on tourism and to some extent on fishing, there is significant seasonality. So people can have even lower rates of employment in the winter months. There is a pattern, and again, every town's different, of higher risk-taking behaviour amongst people of school age, including drug misuse, self-harm and alcohol attributable harms, and relatively lower qualifications than outside the coastal strip. Housing is a major issue. I've given an example here from Blackpool, but it's would be true for many, for example, previous resort towns. On the left is houses of multiple occupation, HMOs, highlighted in purple. These are in places that were previously guest houses, and they've been turned into HMOs, and they correlate very closely with ill health. And you can see male life expectancy on the right, for example, is very poor in these areas. People highly concentrated who often come in with poor physical or mental health. A separate but slightly different set of risks, actually more common on the East Coast, is caravan parks, where relatively poor housing for people in the often later years can contribute to ill health. And then there are significant deficits of medical workforce, and I have to say also the academic workforce in coastal communities. So a really substantial deficit of both doctors and nurses, for example, and these are in areas of relative deprivation and ill health. So this essentially is a double hit to these areas. Environment itself can cause problems. Some of them are simply physical. Some parts of the East Coast are at significant risk of flooding and their impacts, for example. Some of them are to do with transport. So transport links are often slow and unreliable. And that can be including to secondary and tertiary healthcare. Now, I do want to be clear that it's not all doom and gloom. There are many huge benefits of coastal living, including to physical and mental health. Lower rates of pollution, generally. Beautiful environments, places where actually if people wish to be active, they're naturally designed for people to be able to be active. So there are some significant advantages and to coastal living, but against this demographic and socioeconomic background, you still end up with significant concentration of ill health. Just taking an example from your own area, Clacton. If you look at the standardized mortality ratios for under 75s, which is a pretty good proxy, you tend to see really quite high rates relative to the rest of Essex, for example. And the same would be true at the younger end of the age spectrum, child development and educational attainment. Now, I think something which all of you are very alive to, but it's worth just reinforcing. Many of the problems of the coastal strip get averaged out by being lumped in with areas just inland, which are often actually very wealthy in relative and indeed in absolute terms. And so some of the deprivation and ill health consequences of that are missed. And the more granular the data that is there, the more obvious these big coastal effects are. So we made a number of recommendations, but 3 of them I think are probably relevant to the Eastern Arc. The first of which is, in my view, there should be a national strategy, including a national research strategy, in fact, to improve the health and well-being of coastal communities. These, in research terms, are substantially under-researched relative to their relative need, and that's probably exacerbated by the fact that there's a relative dearth of academic institutions that are actually based on the coast, although a few are, such as Brighton, Southampton, and Plymouth. There's a current mismatch in terms of healthcare staff, social care provision, and arguably also academic interest. And there's a paucity of granular data and actionable research into health needs of coastal communities. So I think there is a lot that we could do collectively to improve the health of coastal areas by better provision of data and by better research into both the drivers. I've given some very broad brush drivers, but I think greater granularity of data on that, but even more importantly, possible countermeasures to help improve the situation and decrease the inequalities involved in coastal areas. So I hope that at least some people in these tonight will be interested in taking further some of the things that we could do better to research and therefore improve the health of the coastal strip. Thank you very much.
We can send an email. So can I just ask the panelists, Ed, Lucy, and Abraham, to just join me? Thank you. So I'll just briefly introduce, and then you can always add any information if needed. So Lucy is the director of. Oh, thank you. Yes, it seems. Okay, thank you. Thank you. Is Director of Wellbeing, Public Health and Communities at Essex County Council since very recent, April 2022, and has over many decades, or not so many, some decades of experience. I didn't know whether it was nice to say many decades, 2 decades, 1 decade, of experience as public health and population health as a practitioner and in her role. Ed Garrett is the Chief Executive of the NHS Suffolk and North East Essex Integrated Care Board, and has led the integrated care system since 2019, correct? And Abraham George is the Assistant Director and Consultant in Public Health and Educational Supervisor at Kent County Council, with more than a decade of experience in the Kent area, so region. So thank you very much for joining us today for this panel. And I think I will start, I'm just trying to link to Chris Whitty presentation, and maybe start with you, Lucy. And I think that in the data and the information that Chris has shown us is clearly evidence. I mean, the increase and the over average incidence and prevalence of diseases in the region. And just having your view, and especially mental health, was really, really much higher than in the rest of the region and the country. So just your view on where do you think the problems are, and how we can tackle that above average incidence and prevalence.
Thank you. So
I need to give you this one. Sorry.
No problem. So without repeating, obviously, what a much more expert gentleman has already told you about some of the disparities that people experience in coastal communities, there obviously is a significant challenge, and there's not, obviously a silver bullet to this. So one of the ways that we've been looking at this in Essex is trying to reframe population health outcomes by looking at it through the kind of the economic lens. So understanding some of the economic drivers to poor health outcomes, but also low levels of aspiration, and indeed, as we've talked about, not just physical health outcomes, but mental health outcomes. So having looked at some of the data, and obviously focusing more so on Essex, and in particular, we've got huge disparities in health. We've got some of the most affluent areas in the country, but also the most deprived area in the country that was alluded to this morning around Clacton and J-Hook Sands. So thinking about some of the challenges, obviously we've talked about the migration. We've got younger people who are obviously going out and seeking more employment and education opportunities because there is a lack of significant local opportunities that will provide them with the income that they would be looking for. And indeed, there's also the kind of the juxtaposition of, even if they can find a reasonable job, the housing costs locally in Essex are extraordinarily high. So the affordability actually of high quality living in Essex is a real challenge. So we've got a sort of a brain drain out of Essex, obviously very local to London. Many, many people are obviously travelling there. We've then also got the inward migration of an older population who will have developed risk factors for disease, which then will kind of manifest themselves when they get into our health and social care system. So some of the challenges there obviously are around both understanding risk factors and providing reasonable and accessible sort of secondary prevention opportunities, but then also providing them with good access to good healthcare services. We've talked about the fact that transport links are a challenge locally, and Chris has then just alluded as well to the fact that it's not an attractive place to work on the peripheries of the country for health and social care experts. So even if we do build hospitals, do build GP surgeries, for example, it is very, very difficult to staff them. So we have a kind of, layer upon layer, multifaceted challenge. And without understanding the root causes, the economic drivers of getting good education and employment for our residents, and then making it an attractive place to live and work, to attract people back in to provide the services that we want, we really are going to struggle. Now that sounds sort of doom and gloom, but there are some little things that we can do, as well as some of the big policy pieces that we need to lobby upwards around. So from a point of view of levelling up, it's a brilliant government initiative. Obviously a lot of narrative at the moment, not a lot of funding or indeed some action. So one of the things that we're trying to understand in Essex County Council is, what do residents want? How can we work with our educational institutions, with our local anchor institutions and as an anchor ourselves, to start to sort of generate the right narrative, the right investment profiling, and start to really provide equity in our funding and our resources. It's a very difficult political narrative to say, actually, we're going to stop providing some services in some areas because actually people are able to self-serve and focus our resources on those areas that need it most to level up outcomes. That is a really challenging narrative. It's one that we're starting to have as a system, but again, it is one of the things that is going to take time to make sure that we can obviously get the right investments in the right places. As Chiara has alluded to, one of the things that I'm particularly interested in is mental health outcomes. They are quite often the forgotten element of health and are intrinsically linked again with wealth and also our sort of long-term condition prevalence within coastal areas. So we have the highest suicide rate in the country in Clapton, in Essex, and that unfortunately is a movable feast in and of itself. It's quite an intractable issue, has been that higher rate for quite some time. But it was at one point in younger men, it then went to primarily middle-aged men, again linked with economic outcomes, family breakdowns, etc. And sadly in the last 12 months it's moved back to young men. Again linked to lack of aspiration, lack of opportunities, and as we've seen also links to higher alcohol and drug consumption in some of the coastal towns. So I'd like to be able to outline as we go through the conversation some of the things that we're starting to do, particularly with the university, to better understand some of the triggers, for example, around suicide. But I'll stop there and pass on to Ed, because I know he's linking that sort of discussion to Clacton more broadly.
Thank you. And that I'm going to give back this. I think that maybe you can focus more on the one of the elements that again Chris has highlighted in his speech, that is really the deficit of medical workforce that the region is experiencing, and what is your view as in your role and what we are doing to overcome that.
Thank you, and it's a real pleasure to be here today. It's absolutely a fantastic event, and it's an honour to be on this panel. So in my job, I'm accountable for health services for 1 million people in Suffolk and North East Essex. But what we've set out to do is to prioritise, to put extra effort into our most vulnerable people and our most deprived communities. And so the 50,000 people that live in Clacton is our biggest priority that we have in our patch. I know that's sometimes a difficult message to give, because we want to support everyone, but we're going to talk a little bit about how we prioritise in Clacton in particular, because it's the right thing to do. As Lucy said in a very lucid presentation, Clacton has the highest suicide rate in the country, some of the highest cancer rates, as Chris Whitty said, has some real challenges, but massive assets too. It's an incredible community, and if you work with that community, you can make some real progress. So I was going to just reflect on that and touch upon the workforce issue that you referenced. So when I started working with the community in Clacton in 2019, there were people coming to our board meeting saying they were frightened because they couldn't access a GP. Really worried about that. So, and that reflects what's described as the inverse care law. So often our poorest communities have the poorest access to healthcare. So we put a lot of effort into improving access and quality of primary care in Clacton. We now have 4 practices that have come together called the Clacton Community Practices. And they've done some absolutely brilliant work, including a new surgery that's opened called Kennedy Way, which has a social prescribing garden aligned to it, digital facilities for the community. It's really impressive to see the progress that was made there. We've opened an urgent treatment centre in Clacton for minor injuries and illnesses, which is excellent for the community because public transport to Colchester is really difficult, and if you can't afford transport, if you don't own a car, that's a real disadvantage. The next big thing that we've done is change leadership around community services, which is now much more joined up and integrated with our council partners and with acute hospital partners, and we're actually finding that's a great attraction for workforce because people want to work in teams, they want to work in multidisciplinary teams, and that's really helping with recruitment and retention. The big thing we've done locally is we've just recently secured major national funding for the first community diagnostic hub in the country, which is the Clacton Community Diagnostic Hub. And the benefit for the population there is that if you have an MRI scan, CT scan, an ultrasound scan, you get that in 2 weeks rather than the 6 weeks they were waiting previously. And the commute to travel to Colchester Hospital, which was previously a barrier, has been removed, so we've got local diagnostics there. So I recognise that improving services is really important, but it doesn't change people's health per se. So we're thinking about having built on that asset, how we can really act as an anchor institution. We've set up, aligned to the Community Diagnostic Hub, a training academy where we're giving local people an opportunity to understand about diagnostic employment, creating workplace experience and developing people in terms of building their confidence and preparing them for work. Everyone is guaranteed an interview at the end of the 12-week course, and so far in the last 6 months we've employed 27 people from the local Clacton community into the local NHS, which we're really excited about. Aligned to that, local Kerry, who's sitting in the audience, who's an absolute star. She should be up here rather than me, to be honest. But Kerry is running the Health and Care Academy, which is a cross-departmental piece of work with the Department of Work and Pensions, Health Education England, NHS England and others, to look at creating employment opportunities for the local community. Most amazing stories that I'm sure Kerry can tell about how we're turning some people's lives around through that. And we're going to continue to build on that opportunity. So the point I'm trying to make is that admiring the problem in Clacton isn't good enough. Taking some practical action and building some momentum and confidence is where we've got to get to. And I think moving the health service away from just thinking about services or thinking about it as an anchor institution, as an institution that can create employment opportunities that are wider than probably previously thought about, I think is amazing, and we've got great potential. So hopefully that gives a flavour of passion we've got for Clacton and some of the progress we've made in the last couple of years.
Thank you very much. Thank you, Ed. And I just go to Abraham, and I think that's just going through the presentation from Chris. I think has been very compelling. The data, everyone I think is convinced by the status and the condition of the region. But at the end, it really highlights the need for granular data. The need is one of its recommendations is really to the lack of data and the need for more data. So, what is your view and what is the approach at County Council in relation to data and where we are, what we can do?
Thank you. So, I think from the data that Chris Whitty has presented is very compelling, as you said. Looking at all of those kind of high-level indicators, particularly around prevalence of long-term conditions, the extent of unemployment in different sort of sub-geographical areas. But I think where Chris Whitty is coming from, and I think this is the sort of journey we're coming in Kent, is or sort of going in Kent, is how can we be more of an intelligent customer around how we can actually use the data to actually affect change. And at the moment, the way we use data, particularly in public health practice, is around surveillance and tracking the sort of trend in health inequalities that for example, what Chris Whitty has described. What I've been sort of exploring, particularly over the last few years in Kent, was around how we could start to have a more sophisticated approach on using data to do more advanced analytics. So it's not doing analytics for the sake of analytics. It's about answering really complex questions. So, for example, evaluating different interventions, evaluating what works, risk stratification, identifying which groups of the population or particularly individuals within our population that are amenable for, say, integrated care sort of approaches. And then more importantly, which I think is something that, and Chris Whitty has acknowledged, particularly around the workforce shortages in coastal areas, how do we actually use data to then do very, very sophisticated capacity planning, demand modeling, to actually then disinvest, reinvest, make very difficult investment choices within an existing financial budget to tackle those kind of, deploy interventions and activities to tackle those health inequalities that Chris Whitty was mentioning. In Kent, I'm sure it's just like Essex and the other counties in the eastern area. We're actually a population of almost 2 million in our sort of local health system, covering more than 200 organizations, both within local government as well as the NHS, mostly all GP practices. So I think the key issues we are sort of grappling with, or at least we're sort of reflecting now, is what are the critical enablers to actually make our local health system fit for purpose. So I'm thinking about a shared approach around information governance, a consistent linked data set that we can all access to actually undertake the necessary analytics that I've just mentioned. Pooling together and actually collaborating in terms of analytical capacity. Across those 200 organizations, there's lots of analytical capacity between different organizations. How do we actually work together to actually undertake the necessary analytics that can actually sort of improve the local health system? And it's not just analytics, because then we've got local universities as well as national academic partners who can then help us build up the research and innovation function for our system to actually undertake the necessary sort of, and explore those key sort of research priorities that can actually improve the health system. And then finally, the fact that all of this kind of data analytics and the opportunity to undertake further research, these are fantastic educational and training opportunities. So how can we actually become a learning health system to actually to sort of imbibe that sort of continuous innovation and improvement kind of approach in terms of that, in terms of the overall improvement of our health system. I don't know if that answers the question.
Yeah, no, that's fantastic. Thank you so much. So I'll just do another short round, and that I was thinking, and Lucy, you mentioned the work you are doing with the university. So I think I'm going to pose the same question to every one of you, and it's really how we can benefit from a proper functional partnership across different stakeholders, in which university is one of those stakeholders. So I'll just start with you, Lucy, and then if you can just go through.
Thank you. So for me, universities, I think, have been, and we've talked about it sort of earlier today in different forums, they've been one of the key organisations that's been missed out of the kind of national policy around integrated care systems. I think thankfully locally we've recognised that gap, and there is a lot of engagement both with the anchor institution work, but broadly just at a kind of an executive partnership level. So, the very practical example that I'll give is the fact that I've been in the system just under 6 months. Obviously, I've already made contacts with Chiara. We're very fortunate in Essex to have the Institute for Public Health and Wellbeing. So I've got a kind of a ready-built and new and looking for exciting innovation sort of opportunities organisation on my doorstep. But we've, again, been focusing on looking at the suicide issues. And we are now just starting to work with our coroner to look at a new data set that isn't sort of routinely utilised or even sort of accessed, to do some very specific work to look at whether there are linkages between particular population groups and characteristics that mean that somebody is more predisposed to attempt suicide, or indeed in this case, it's coronial case known as complete suicide, than the general population, so that we can sort of better understand risk factors, trends, triggers, and also obviously improve our preventative services, albeit that actually only about 2/3 of people who complete suicide are actually known to any kind of service at all. So, there are some real hidden challenges around health outcomes in coastal communities. And because some of the community networks are broken down, because people, as we talked about, there's quite significant migration, they don't always have the social networks that you would want, particularly to support around mental health issues and illnesses. So we're working with a range of different groups, including the psychology department, a member of whom is here as well, to start to do that work over the next couple of months. But more than that, we've talked about the anchor institution responsibilities. We are significant employers, local authorities, NHS organisations and universities. We've got a responsibility to make sure that there are adequate and equitable opportunities for all of our residents, and to develop people internally when we do that. We need to make sure that when we're talking about the economic crises, that actually recognise some of those poorest paid employees locally are our own employees, and we have a duty to make sure that we do what we can, recognising our funding challenges, to make sure that people have the minimum that they at least need to live on, if not more, but provide them with opportunities to progress rapidly with the right support. So we also have opportunities around the workforce pipeline, and again, each university has its own sort of organisational specialty, so not everybody will be doing this, but there are not only the health and social care challenges around workforce, but we've talked about the economic opportunities that are unique to coastal communities around green infrastructure. We need to be developing with our schools and our colleges the workforce of the future to develop those innovations, maintain them, etc. And again, we've got to be really forward thinking and slightly less risk averse in developing programs of work that support people to do that. We have to invest locally and think very much to the future, but if we're going to sort of get under the real kind of skin of the challenges.
Thank you. Ed.
To follow that answer, let me think. So from an NHS perspective, the last 30 years, culture's been based on competition, and it's been really toxic, I think. So we're now moving much more to a culture based on collaboration, and as my colleague referenced earlier, learning, because we're not going to improve outcomes for our population unless we start learning and developing and growing together. So I'm very explicit that I want to build our local integrated care system around our local universities and other educational partners, because it will help to foment that culture and I think build real sustainability. And there's such talent in the university sector that we've got that we can collaborate together. I think it's really, really exciting. There's a load of work being generated at the University of Essex, and Rob, who's just over there in the front row, we're working together on a potential care tech hub based here in this part of Essex, which is really, really exciting for the social care workforce. In Suffolk, the University of Suffolk, we've established an integrated care academy, and got all sorts of work ongoing, including building integrated care into curriculum, putting on leadership courses, bringing together different professionals to learn together, and drawing in research grants. So we've been able to get a lot going very quickly. So I'm really excited about this new partnership, which I don't think is happening necessarily everywhere in the country, but I think it's a very great opportunity. And then the final thing, and it's obvious working with Kiara and many people here, is that we're aligned around social justice, equality, tackling the health inequalities. I think the more we align together and push together, the better impact we'll have for our population. So I'm absolutely bought into this partnership.
Thank you, Ed. Abraham.
So I've been mulling over the whole research agenda and the ambitions for research for our team. It's been particularly difficult considering working in a county council that ever since I started 10 or 11 years ago, we've always been told, okay, we need to make savings, we need to make funding cuts. And so how do you actually how do we actually try and innovate and actually do something creative within, and at the same time achieve an ever-reducing financial balance. So fortunately, I think what is quite interesting is the sea change that is going on, particularly in the NHS. The creation of the integrated care boards, and more recently the guidance for integrated care boards in terms of developing the integrated care strategy. And the emphasis on research and development as a critical section in the strategy development. So that's something that's been a real, support for me to articulate and advocate the importance of research, particularly within our council. In that regard, I've managed to garner some funding to get some help to actually do that. And in fact, editor it's not just who happens to be the head of research and innovation at one of our local foundation trusts, very graciously taking on the challenge to help me set it up. So this is about building up the function not just within public health, but actually broader within the wider council. The other signal that's happening nationally is, some of you may be aware, is the new NHR funding call that's called Health Determinants Research Collaboration. What I understand is that the first round of funding has already been agreed, and I think there have been a few local authorities that have been successful in that funding round. Unfortunately, for lots of reasons, we weren't able to apply in time. But I guess the point I have made to our Director of Public Health was that we don't need to wait for funding from National Institute of Health Research. Let's just get on with it and start building building ourselves to become HDRC ready or HDRC compatible. So in that regard, we're already capitalizing on existing research network and collaboration. For example, so Kent has got the unique opportunity of being part of two ARCs at the moment. That's the Kent Surrey Sussex ARC collaboration as well as for the Eastern ARC. So we're having those conversations with local universities as well as other ARC organizations around where we can start to apply for, particularly around funding. And but obviously coastal health and the coastal access in terms of inequality is a top priority for us. It's been already articulated in our Director of Public Health report last year. And so it is the intention that we would want to start to emphasize more research around that. The big challenge we'll have, and I'm sure that Essex and Norfolk and Suffolk County will have the same thing, is that the delivery of health and well-being interventions for our coastal communities is not just ordinarily just delivered by county council. We have a relationship with our district councils as well, and they have a huge amount of data, useful data, particularly on vulnerability, that we can actually capitalize on and integrate with county council data as well as the NHS data to actually do some of that research. So those are the conversations that are currently going on in Kent. Kent having the largest number of districts to collaborate with. We've got 12 districts in our batch. It's not an easy conversation to have. And it's likely that we can't short circuit the conversation, particularly around data integration. We might have to do it district by district. But things are changing, and there is some work already going on in terms of data integration within the districts. We are now trying to push this and actually encourage districts to link in with the NHS, to link in particularly data from the healthcare side, in order to then undertake and then make that data accessible for research purposes, and then collaborate with our academic partners to develop suitable research studies and funding priorities.
Thank you so much. I think, thank you, the three of you, for really, really inspiring and a lot of information. So I would like to open to the floor to questions. And I just need 3 minutes at the end, but we can go just 5 minutes over, right? That's great.
Okay, this is a question really to you all. But if I go back into the mist of time, we talk about the immigration of older people into coastal communities. But I recall, certainly around Thanet, that there was an awful lot of people coming into the community who were in some form of benefit receipt, who were being placed out of borough from London. So would that unnecessarily contribute to the slant towards mental health, physical health, deterioration or lower levels thereof? And if so, what can we do to fight back with the other colleagues? Because it costs us money.
Thank you. Who would like to take? Oh, that's great. Someone.
I mean, usually that comes under my head, so I'm sure it's been. So, I mean, this has been a problem that's been going on for years and years. So the particular group that you're talking about is particularly around looked after children from other London boroughs. And the simple reason, as you know, is because of the costs of actually housing them. That's why they get housed in, particularly in coastal areas like coastal districts like Thanet. There's no easy solution to this. It's a political football that's between both local government and the national government around the process and the procedures around, or the decision making around how to actually house out of area local placements. I think the idea, this is probably where Chris Whitty comes in, because this is about the use of more granular data to actually then argue for the case for change and argue for more investment in these coastal districts. So should they be subject to all of these national government policies or of shifting deprivation further up from inner city boroughs onto coastal communities? But the simple answer to your question is yes, it has a huge impact on us. In fact, if I'm not mistaken, Thanet is on the top 10, is in the top 10 most deprived areas in the country. And this is a significant factor in that regard.
Thank you, thank you. Would you like to add anything to?
Just a small reflection. So I guess my reflection is it's not just a coastal issue, but there is a lot to do, and I'm not trying to make a political point. You know, I try to stay clear, and particularly working for a political organisation, but there is a lack of thought around some of the sort of central government policies that displace different groups into other areas. Now, with the best intention, I am sure, but actually, you know, your example is really good. I'm a child that was born in North London, whose family was council housed, and there was an opportunity to move to the new city of Milton Keynes. Exactly. So, you know, again, there wasn't a thought about building community cohesion and infrastructure there, although there was investment in the kind of the physical environment. But another more contemporary example is around the Home Office identification of locations for bridging hotels, for example. They are quite often put in the most, you know, out of the way, inappropriately served areas, quite often that have, you know, very difficult political makeup around, you know, sort of immigrant groups. And where we sort of scramble at very short notice to ensure that there's adequate provision for needs that are, until they arrive, pretty much unknown to us. And there are a group of people who, and we've talked about data collection, but with the best will in the world, even if we had better data on them, this is about trust, and this is about, you know, building the right relationships with people and understanding their behaviours. And we were talking, Kerry, earlier about it, weren't we? That quite often we come in, we think with the solutions, when actually when you talk to the communities that we want to best support, they have a very different perception of what the problem, if we want to call it that, is, and indeed have solutions of their own, but just aren't listened to. So I think quite often government policy with the best intention can be ill-executed, and we have a responsibility to be communicating better ways to do things upwards.
That's okay.
Thank you. Hi, I'm Emma Wilcox. I'm the Director of Creative Estuary. It might seem a little left field question, but you talked about not being able, it's very hard to recruit healthcare staff to coastal communities. And I suppose I wanted to ask a little bit more about that, because part of the work that I do, which is about using culture to change the future trajectory of places and creative industries in that way, it's about attracting high-skilled jobs in lots of different sectors, so we're sort of facing real problems. So I suppose it's the question about what do we need to do in some of those places more, you know, that will have that knock-on effect of improving them in every way, which would help also attract some of your medical staff. But also I wanted to mention here that obviously we also have the training of practitioners and needing. Someone talked about earlier today that doctors who are undertaking medical training should absolutely work in their community as part of their training. I can't remember who said that's a great idea. To really understand that community and be rooted in it. But yeah, just to talk about that, what is it about those places that you think particularly makes it hard to attract doctors and nurses and practitioners? Sorry, all.
Ed.
Paul Rollins. I was speaking to some GPs in Harwich, which is a similar community in some ways to Clacton on the Thames coast, and they were saying that they love working in Harwich because it's really difficult. It's difficult medicine. You see patients with a lot of complex acute. This isn't the worry well. This is people that are genuinely unwell, but you really have to want to do it. Otherwise, you'll get overwhelmed with the workload. And I think that's the challenge people are concerned about working in deprived communities as a GP or medical professional with a nurse because of the workload and the complexity of the patients and clients they see. I was wondering whether we could build on that mindset a little bit actually in the conversation with the university, because is there a link with the university about joint roles where people with an interest in deprivation, interest in health inequalities could combine academic work with working as a front line in communities like Clacton, and maybe actually turn it into an asset rather than seeing it as a deficit and a challenge. So I think there's something around that. I think there's some of the gains we're starting to make now is really link up the voluntary sector, who are much more agile and creative in the way that they support people and bridge statutory services with the community. And I think creating really joined up services with the voluntary sector is an attractive proposition for people to come and work in coastal communities, and I think that's definitely something we're pursuing and want to pursue further. And then the third thing, as I said, is we really need to be excellent in our coastal communities in terms of the integration of health and social care and multidisciplinary teams, because people, as I said, really like being in those teams because you're taking out the duplication and the frustration of passing people you're caring for from pillar to post. And so really creating that integration, that strong leadership will attract people to work in coastal communities. But we have to really think differently and work at this, because if it's just treated equally, you find that people won't want to come because of the workload and because of the complexity.
Would you like to add anything, or
Yeah. So the only thing,
Lucy?
sorry, I feel like I'm talking too much, but I think the only thing that we probably need to recognise is the adult social care element to this as well. I think there are great opportunities if you are that way inclined, and as a clinician I was, which is why I'm stuck in public health, to go to more challenged areas. But it is a real challenge, for example, for adult social care. They are on national living wage, if that. They can get paid more working in an Amazon warehouse, and they don't take the guilt of some of the things that they see and feel they can't do home with them at the end of their shift. So that is a real challenge, and obviously without an appropriate adult social care workforce, then actually our bottlenecks occur in hospitals, etc. So it is really difficult. I think the other thing that we've got a duty around is workforce wellbeing, because even those clinicians that are really engaged in working in more deprived areas, there are those days, and they become more frequent, over time, where in your appointment you are not able to address the issues. That person isn't going to go home to a warm home, isn't going to go home to a decent meal, isn't going to go home to a supportive environment, and therefore actually what you can do as a clinician is really, really limited, and it does feel like a kind of sticking plaster on a gaping wound, and that takes its toll on people over time. So we need to make sure that we recognise the additional emotional drain that working in those environments has on our workforce and support them accordingly. And I'd also say that for our education staff as well, all the way through the education system. So again, it's one of those real challenges that people get burnt out.
Thank you. Is there any, we take the, I think the last one. I'm looking at the Phil.
Thank you. I'm Farah Brownie, a previous Darcy Fellow at Kent County Council, just finished now. So my question is kind of to all of you, but also targeted as well. So Lucy, you mentioned taking more risk-averse decisions, and I kind of wanted to kind of dig into that because working at Kent County Council has been amazing as a fellow, but I've also had no loyalty, so really have pushed the buttons, disrupted a little bit more than I planned to anyway, but it came across, I know we've talked about innovation myself with Abraham in that sort of cycle, but doing the Kent and Medway Listens project, essentially bringing things to the table like signing up for national living wage and those big asks that are possible, were really, I don't want to say battered down, but really perplexing to bring to the table and really difficult to bring to the table. And some of these conversations, although are happening nationally, it is really tricky to navigate those waters, especially when there's quite a hierarchical kind of bureaucratic kind of system already in place. And coming from this kind of Darcy Fellowship, blue sky thinking, systems thinking, innovation is like at the core, co-production, you name it, we want to do it. It's really hard to kind of marry those two up together. So what I guess my ask is, how do all of three of you kind of plan to tackle or hope to tackle and have those risk-averse kind of plans in, when you've got commissioning cycles, retention is difficult, and essentially bringing things to the table is difficult.
Thank you so much. Let's start. Good luck.
I think it was not one person, but probably 10 persons. I think workforce planning is probably the most acute problem that we're facing right now. It's interesting to note, I think in terms of research, I remember seeing a presentation many years ago from Professor Kieran Walsh at the University of Manchester, Professor of Health Policy. He was showing a very, very striking statistic around £12 billion that are spent annually in health research. Approximately it's about 60-70% of that research is all on drugs and devices. But actually, if you look at it in the NHS, 60-70% of our spend is all on workforce. So I think there's clearly a mismatch in terms of priorities, research priorities, and what we need to be focusing on. I mean, I don't think that there are any short-term fixes for recruitment and retention that county councils can actually do at the moment. But that's just my personal opinion. There may be offshoot opportunities, say around digitalization, for example, the use of shared care records that might help to a certain extent optimize some kind of the, say, the deployment of integrated care, so integrated care services, integrated care teams and things like that we can explore. But I think they will only have a little impact in terms of the overall, little effect on the overall health impact in the population. I think until we actually sort of address some of the key issues that both Lucy and Ed have mentioned, I think it's going to be a really tough nut to crack, particularly to try and tackle the recruitment and retention issues in the short term. That's what I say at the moment.
Yeah, you definitely need to take some risks. I probably should have been sacked for some of the things I've done, but thankfully they've come off. So I put money into citizens advice bureaus, which, for example, you wouldn't traditionally put health service money into CABs, but the support they provide to people's mental health and well-being is huge, and therefore prevents demand later down the line. As an example, today's wacky idea I was thinking about was having a chat to Lucy and counterparts in Suffolk County Council. So travel costs is a major issue for paid carers, a massive issue, and for some people they're thinking actually I'll work in a different industry because the cost of travel, especially in big rural counties, is a big issue. So could the health service invest in electric vehicles, lease car schemes to support our carers to get to work and back and create incentive to stay? That might be a stupid idea, but we've got a lot of resources, but let's think creatively about how we use them. In my view, this is the North East Essex pound, this is the Suffolk pound, this is the Norfolk plan, whatever, let's not try and silo it into, and this is NHS funding, we can't possibly support that because it's NHS, other sectors thinking similarly. So I think we just need to look at the resource as one part, let's make the best use of it. Let's go with things that are evidence-based and the data supports, as everyone was saying, and let's take a punt. We'll make a difference if we don't take a risk.
So this sounds counterintuitive, but for me, making the riskiest decisions means devolving the decision making. So I have to be honest, if we go back to first principles as to why we're all here, then we are here to provide services that help people, become well in the first place, remain well, and then for as long as possible, remain independent in their later life. If you go out to the public, our residents, our patients, whatever you want to call them, and ask them where they would like to see money spent and how they would like to take decisions, they are much less risk averse than we are. Even sort of small pieces of research around outpatient follow-up, for example, we're obsessed with it as clinicians. We must see this person again. And actually when you ask them, do you want to come back, or I could give you a phone number for a triage nurse and just you can give them a call if you have any concerns, it's about 75% of people don't want to follow up. Actually, it's a huge inconvenience. They've just been off work to have a minor op, or whatever the case may be. And actually we sort of impose that paternalistic view of how things should happen still far, far too much. If you start to speak to residents about, albeit that there are statutory responsibilities, but the use of the discretionary council budget, they put it in all sorts of amazing places that actually have much greater impact. So for me, it's actually about not me being less risk averse, it's about getting our system to trust the people that we're serving to know best what they need and how they want to provide.
Thank you very much, and thank you for the questions. And I think I reduced to 30 seconds. I'm really sorry. I was 60, but now we go to 30. And I think it's just your 30 seconds message that we can bring each one of us back home for action, intervention, for research, for advocacy. What is that we can bring back home and tonight think, okay, I'm going to work on that to improve the health of our coastal communities. 30 seconds.
So for me, it's obviously pushing forward with the mental health work and making sure that people obviously are part of the discussion that then unfolds from the outcomes of the research about how we can improve services. As I said, what this is about is providing the services that people want and need, not the things that I think as an expert they might want.
Thank you. Ed.
Build on your assets, build with your community, build confidence, and make decisions.
Thank you.
Be an intelligent customer, ask the right questions. And if people say, no, you can't access the data, we'll say, then tell us how, rather than just accepting no as an answer.
Thank you so much. And can we just round up?